Good evening, everyone, and welcome to the Pacific Spine and Pain Society's training webinar series. This is session 4, spinal cord stimulation. We are so excited you are here tonight and you have joined us. We will give everyone a few more minutes to join the webinar. We will start the webinar promptly at 6:02. Thank you again for joining us. We will start promptly in 2 minutes. Good evening, everyone, and welcome to the Pacific Spine and Pain training webinar series. We are so glad you have joined us tonight. This is session 4, focusing on spinal cord stimulation. We are so excited you're here. The session will begin promptly in 1 minute to give a few more people time to log on. Again, welcome to the PSPS training webinar. The webinar will begin promptly at 6:02. Good evening, everyone, and welcome to the Pacific Spine and Pain Society's training webinar series. This is session 4, focusing on spinal cord stimulation. We are so glad you have joined us this evening, and I'd like to introduce our moderator, Dr. Kasra Amir-Delfan. Dr. Amir-Delfan, take it away.
Thank you so much, Michelle. Good evening, everyone. My name is Kasra Amir-Delfan. I'm the Vice President of Pacific Spine and Pain Society, and it's my pleasure to welcome you to session 4 of Pacific Spine and Pain Society's webinars on spinal cord stimulation. As many of you know, we had this webinar scheduled for a previous date. During that webinar, we were hacked, and we were all the subject of terrible racial and sexual comments by the hackers. We clearly condemn any and all comments made beyond our control during that webinar, and we apologize for that mishap. We opted to end the webinar early, and we scheduled it for tonight. Obviously, this truly distressed the audience, our members, and our colleagues outside of our society as well. But in a way, I'm glad it happened, and I'm going to tell you why. In our field, we all work with colleagues and patients constantly, and we rarely see race, color, sexual orientation, or religion as any kind of an issue during our personal or professional interactions. The events of the recent webinar was a wake-up call for all of us to realize that we need to do more to eliminate any prejudice of any kind, not only in our own community, but also beyond. This was a call to action, and we've already taken a number of steps towards this goal within Pacific Spine and Pain Society. But we can't do this without you. There's strength in numbers, and we can get much more done with your involvement. It's time for all of us to raise awareness about any inequality in our own space and beyond with one loud voice. We will continue to make our corner of the world beautiful, and hopefully that will have an infectious effect on the rest of the world as well. With that, let's get to the clinical portion of this webinar on spinal cord stimulation. The learning objectives are we're going to learn about the basics and the advances in technology with spinal cord stimulation and identify indications for dorsal root ganglion stimulation and describe its techniques. Beyond that, we're going to learn about new indications with spinal cord stimulation and how to manage complications. Next slide, please. I am going to be your moderator tonight. I'm a partner at IPM Medical Group in Northern California, but I'm not alone tonight. I have a group of star-studded faculty who have joined me to help me in this particular endeavor. Next slide, please. I'm going to invite the faculty to come up at this point, actually, so everybody can see it. So our first person is Lawrence Poirier. He's a professor at UCSF, and he's a dear, dear friend. He and I did our fellowships together at the same time, and I've learned so much from him throughout the years. And he's going to talk to us about lessons learned from SCS failures, past and present, and the future. Then we're going to have Krishna Chakravarti from UCSD talk to us about the dorsal root ganglion stimulation. Next is Dr. Samir Sheth from UC Davis, and he's going to talk to us about management of complications and review the NAC guidelines with us. Then we're going to get into a demonstration of technique, and that's the practical portion of it. Since we can't really have a cadaver lab in the age of COVID, we have demonstrations on a cadaver. I myself, I'm going to show you how to do a spinal cord stimulator trial, followed by Rama Naidu, who's going to show us the permanent spinal cord stimulator implant. This is followed by Jackie Weisbein, who's going to show us a DRG implant on a patient. The film was actually Dr. Jason Pope's hands, but Jackie's going to describe it for us because we all know she's far better at DRG than Jason Pope is. Last but not least, we have Sloan Yu, who's going to talk to us about superior middle conial nerve placement. At the end, time permitting, we'll have a roundtable discussion with all the faculty, and we'll try to answer as many questions as we can for all of you guys. So without further ado, I'd like to invite Dr. Lawrence Poré to take it away for us. Lawrence, the floor is yours.
Great. Thank you very much for the invitation, and it's great to be back to discuss this in further detail. My disclosures are here. I do a fair amount of consulting with a number of neuromodulation technologies. So let's start with understanding where we are, where spinal cord stim started. As with any good therapy, it starts with a good idea and a good theory and a hypothesis. And that was the gate control theory of Melzack and Wall back in '65. And shortly thereafter, we started exploring spinal cord stimulation. Early exploration with intradural leads, like the one you see here to the left, resulted in scarring of the spinal cord and infection, and were soon abandoned for epidural leads. Next slide, please. In the 90s and early 2000s, we found that spinal cord stimulation was far better than repeat spine surgery for people with failed back surgery syndrome. This work by Dr. North showed that 50% of the people were able to receive 50% pain relief with spinal cord stimulation, and they did better overall than those patients that had reoperations or dorsal root ganglionectomies. And for the time, that was pretty good. We called it the 50-50 club, and we're quite happy with those results. But clearly, if you only have 50% of your patients getting benefit from a therapy, it makes you wonder about the other 50%. So next slide, please. We were faced with a number of challenges in the late 1900s, things like patients needing to have MRIs when they couldn't with the devices that were available at the time, short duration of battery life, high cost, low efficacy for some pain conditions like back pain and isolated foot pain, positional variability with CSF layer at different levels, as well as that 20 to 50% non-responders, and most importantly are the 20 to 30% explant rate we see at 2 to 5 years. Next slide, please. So the beginning of the 21st century here was focus in on how do we improve the technology that's available, the technology of MRI compatibility, the batteries needed to become rechargeable for many instances, and things of that nature were rapidly developed by our engineering colleagues at various companies, and they did a great job. Next slide, please. So most devices these days have those things addressed. The high initial cost remains a problem. So after the turn of the century, our big focus was on the back pain and isolated foot pain, but mainly the back pain. A lot of our patients with failed back surgery syndrome have back pain, and by the time we were able to get enough stimulation in that area, people would have a tremendous discomfort from thoracic stimulation. Next slide, please. And we understood that that was largely due to the fact that the low back fibers were lateral on the dorsal columns there. And next slide, please. And when you stimulate over the dorsal columns, that stimulation parameter, in order to get those lateral leads at T12, resulted in stimulation of the thoracic rootlets. Next slide, please. So new technologies were developed, paddle leads and tripole configurations of PERC leads, current steering with various devices, all allowed us to reshape that electric field. And the technology has been very good at that, and thereby avoiding some of that thoracic root stimulation. And that certainly improved our successes with low back pain and other hard to reach areas. Next slide, please. However, it still left us with this. This is a study from Van Boyten in 2017 that looks at the probability of explant. You can see here on this graph that the time from 0 to 5 years on the x-axis and percentages going up the y-axis there. We're looking at about a 20% explant rate for spinal cord stimulation over the period of 5 years. Next slide, please. So some of this was due to CSF variability. In order to get that stimulation, patients will either turn it up and get overstimulated or turn it down so they didn't get overstimulated, but then wouldn't get efficacy. And there's a lot of challenge with the variability of the stimulation day to day and minute to minute, actually. And we're still looking at a 20 to 50% non-responder rate. Next slide, please. And so the focus here was looking at what does that CSF flow look like. We know there's a caudal and cranial motion of CSF with the spinal cord with the heart rate. Next slide, please. And motion is certainly one that we see with each actual heartbeat and each respiration. The target here is X may or may not be within the actual electric field at any given time. And so you can see here the bright spot in the far left. Many times good stimulation to get the X will also end up stimulating far laterally and causing discomfort. Next slide, please. So there's been a couple of approaches to that. One approach was to look at a accelerometer, just like the one you have in your, maybe not just like, but similar to the one you have in your iPhone, whereby you can change the calculator just by changing the orientation of your iPhone. And this is good for patients that were either laying down or standing up, but it didn't really address some of the variability that happens with coughing and heart rate and respirations. Next slide, please. But it was a good start, and it's a good technology. Another approach was just to avoid the CSF altogether by stimulating out the foramen and getting the dorsal root ganglion itself, where there's very little CSF layer. And of course, there was a variation in frequency. These frequencies were often, especially the 10,000 kilohertz, was above the stimulation paradigm by which a person could sense that sensation at lower amplitudes. And so this was studied to see if it could provide analgesic benefit as well as the burst stimulation, sort of the packets of 500K bursts intermittently could also be provide neural activation without sensation. We can go ahead and skip this slide and go into the next. Dr. I think it's Krishna or well, it's fine, we'll talk about DRG. But let's look at the results that resulted in these changes in technology and the fact that we're trying to address that 50-50 club. Here is the DRG accurate study showing that the 3 months we have an 80-50. So 80% of the patients getting 50% benefit as with DRG stimulation as compared to spinal cord stim, which is still down in the 50-50 club. I'd like to draw your attention to the 12 months data that shows that there's about a 10% reduction in efficacy for the stimulation at 12 months out, but still very good, much better than traditional stimulation. Next slide, please. So how about the high frequency? Certainly we've seen that come on the market and show benefit for that low back pain. Next slide, please. And over the course of 2 years, which their study carried out, we saw that they also were approaching that 80-50 club for both back and leg pain. And over the course of not just 1 year, but actually 2 years, they were able to maintain good analgesic benefit. But once again, we see that 10 plus reduction over time, but still much, much better than what we see with conventional stim, which you see there in the tan and brown boxes there, which still are at either 50% or less than 50% at 2 years out. And so we certainly have seen that the new technology has helped. Let's go into the next slide. The concept of the burst stimulation, combining both low frequency and high frequency together, or the burst stimulation with low frequency stimulation, was able to together provide greater benefit than either one alone, as noted in this study. Next slide, please. And so these studies provided a foundation for what I consider the new era of spinal cord stimulation. Since 2000 and 2020, we have had tremendous leaps and bounds in our technology and the capability of pushing our envelope from the 50-50 club to the 80-50 club for most cases. And that's where I think we are today. But the question is that good enough? Next slide, please. We still see changes that are the result of technology changes. Next slide, please. But we still have this explant problem to contend with, this 20 to 30% explant rate between 2 and 5 years. Next slide, please. And here we see results published by Jason Pope, looking at loss of efficacy at 43% over the course of just 13 months. He reports 25% of all patients will be explanted due to device failure, and most of that device failure is just lack of efficacy. I'd like to draw your attention to the results of similar explant numbers for cardiac pacemakers. Their explant rate is about 96%. Of those explants are only for end of life of battery. The other 4% are for complications of infection, lead fracture, and the like. And their number of explants due to loss of efficacy is 0. There are no pacemakers that fail to stimulate the heart if there's not a technological problem with the device, because they have understanding of their physiology and what they're measuring. Next slide, please. On a where we failed, I think, in this field up until recently, is to understand the individual characteristics of the patient, understand what's going on with that individual. We've done a great job with the engineering, but spinal cord stim remains a physiological black box, especially as the individual physiological changes are occurring. We are not really, we haven't been focusing our attention there, and I think that's where the future lies. Next slide, please. When we go back and look at pacemakers, of course, they have an EKG to monitor, and they're adjusting their devices with that EKG. Here's a recent study that was just presented at NANS. It's a sort of a spin-off from some of the much of the work that's been done by Ricardo Vallejo, looking at other cells besides neurons. In addition to neurons, looking at the glial cells, microglial astrocytes, and oligodendrocytes. And notice that after a spinal nerve injury, like we see with a variety of the patients we see, they actually have a different expression of their glial cells, more of an inflammatory expression, an expression which can be picked up on looking at their RNA synthesis and development there. And with spinal cord stimulation at various frequencies, high frequency and low frequency, those cells can be returned closer to a more normal state, less of that inflammatory mediators that they're releasing. This is very exciting work that was first done in animals, and this is a next slide, please. First 3-month data was presented just recently at NANS. And once again, what do we see here? Really interesting. Once again, we're back to the 80-50 club. See that graph there in the middle? 80% of the patients getting 50% better as compared to conventional low-frequency stim with only the 50-50 club. So the issue here is that we don't have a mechanism readily available to actually monitor this for individual patients, at least not now. I want to sort of highlight some very preliminary research being conducted by Adnan El-Kazi at Guy's and St. Thomas Hospital in London. None of this data has been presented. I'm not presenting any data, but just the mere fact that he's starting to look at and collect monocytes from spinal cord CSF from patients before and after their spinal cord stimulation to see how this inflammatory process can be modified in individual patients, so he can then determine if there's something that is a target there that can be monitored during the therapy of the patient. That's what we need. We need to monitor our patients, understand what they're doing, because things change. Here we see the EKG I was talking about before, which is sensing the pacemaker sensing the EKG on a beat by beat moment and making that decision. Did the atrium fire? Did the ventricle fire? If not, should I fire the atrial lead or the ventricle lead or both? And if you get overstimulate, you see V-tach. This is how cardiologists actually monitors the function of their device and how they program their device. They don't ask the patient, are you feeling lightheaded today? How are you feeling today? Should I go up? Should I go down? Should I turn it off? What do you think? That's really where we are at a disadvantage. Next slide, please. So one approach to this, which is just been published in a couple of recent articles, is the ability to actually measure the electrical activity after you stimulate the spinal cord. Look at what the neurons are actually doing. How are they firing? How are they responding? And are those responses correlating with the patient's analgesia? And if you can correlate these responses to the patient's analgesia, then you can set the ideal neural response, not the response the patient might give today, tonight, tomorrow, or how the response might occur when they stand up versus lie down, but the actual neural response itself by measuring the evoked compound action potential off the same lead they're stimulating from, real time with every single heartbeat and every single respiration. Next slide, please. This says, oops, we skipped one there. Here, when we actually measure the evoked compound action potentials, we see this huge variability. The pink there is overstimulation, the blue is understimulation, and the white bar there is ideal stimulation. And you can see with just normal daily activities, walking, standing, coughing. Coughing can lead to up to a 10-fold increase in stimulation of the ideal targets on the spinal cord, causing lots of discomfort for patients. So you can imagine someone with a bad cold would just turn their device off. There would be too much variability to account for the pain relief they were seeking. Next slide, please. Once one can identify that therapeutic window, next several clicks, please. That can be identified by correlating these ECAPs to what the actual patient is responding to, and then setting that as the target. Once that target is identified, that target, the neural response target, not the output of the device, but the neural response target can be set as the patient's ideal setting that they help to, in coordination with the doctor, set. And that can be the level that is set when they leave the clinic. Next slide, please. So what we see here then is once that is set and is locked into the ideal, next 4 clicks, please. Next, locked into the ideal stimulation parameters for that patient, then every stimulus can aim toward maintaining that same neural response, regardless of motion, regardless of coughing, regardless of what else is going on. And that's what allows patients to get the stimulation in the area that they choose. Next slide, please. Now, to compare this with fixed output, which is all the other devices on the market today, fixed output does not make that adjustment at the top slide. Please, next click, please. When you make that adjustment, you'll see that the evoked compound action potential stays in a very narrow band, regardless of what activities the patients are doing. Next slide, please. And so here is the recent publication, just came out in February this year, Lancet Neurology. It's a double-blind randomized controlled trial, one of the first, I believe, in the double-blind fashion. So neither the physician nor the patient knew whether they were in the open loop or the closed loop because they used the same device. They were both programmed with lower frequencies, but one with control of that evoked compound action potential, and the other one without control of that evoked compound action potential. Both, however, were initially programmed with evoked compound action potentials, and that was the first physiological measurement of programming decisions. So the gray bar there line looks very good, but when you actually control the device to actually maintain the ideal neural response, you can see that they did much better in the blue line. Next slide, please. In an open label, much smaller open label study, the same 80% response rate was seen. But really what's interesting over the course of 24 months, and this is a small study, needs to be repeated, certainly some dropouts and only 38 patients here at the end. But nonetheless, the trend was upward instead of downward, and that hadn't been seen in any other studies and something that needs further exploration. However, what's notable about this is that if a patient comes in, next slide please, and they are not doing well, as in this case, if they're not doing well and they're noted to be outside the therapeutic window as that middle negative 38% bar down at the bottom there, you see that only 56% of the time were they in the appropriate therapeutic window that they had set 3 months earlier. Obviously something has changed and is no longer effective. And so that can be adjusted based on the individual's physiology. That's the key point here, is to understand that we see failures all the time. Every device, every study sees failures over time. The question is, how do you address those failures? How do you understand those failures? And if you can't understand the underlying mechanisms and underlying physiology, you can't make a decision. Next slide, please. Here, what we've seen that was not part of the study, but which is extremely interesting and took everybody by surprise, was the fact that over the course of this 2.5 months here, this particular patient had a therapeutic window here on March 1st that was pretty wide, and they programmed accordingly. But as the patient decreased their gabapentin, their therapeutic window lessened, And so just to make sure it was drug related, the investigator actually restarted the gabapentin. Sure enough, it went back up again. Then he went ahead and titrated off all the opioids and the gabapentin. And over that course of that next month, you can see that the therapeutic window is now only 22% of it was initially, meaning that there's a lot of extra energy that's needed when you are inhibiting the system by which we're trying to recruit analgesia in the first place. Something that, when you think about it, seems like something we should have anticipated 50 years ago, but now we see it in real time. And here's the most interesting study that just came out last year by Julie Politz's group, looking at duloxetine improving spinal cord stim outcomes, which would make sense because the norepinephrine pathways are part of these inhibitory control pathways, and this is enhancing that process. However, what she also wrote in a small statement on the side was that gabapentin and pregabalin did not significantly affect pain outcomes positively, but in fact increased perception of pain. So the very drugs we're giving the patient to inhibit their pain are the same drugs that are making spinal cord stim not work. So no wonder what we saw earlier was changes over time, because patients are asked, and often do, titrate down their opiates, titrate down their neuropathic meds that are causing CNS side effects and cognitive dysfunction. And yet we're pretending as though that nervous system and the way we stimulate and program that patient a year out after they stopped all those drugs is exactly the way it was on the day we did the trial. Doesn't make any sense at all. That's the future, is understanding the individual physiology of the individual patient and making individual changes. That's the future of spinal cord stim. Next slide, please. So therefore, when we go to select a device, it's not about selecting a device based on which device, failback surgery syndrome doesn't need device A, B, or C. It's about what device, what condition, and what are the characteristics of the patient. And when I ask the fellows to evaluate the decision for any given patient, for any given stimulation plan, they have to review both the safety of the device. Usually that's an MRI compatibility issue, appropriateness for the individual. Maybe some individuals like rechargeable, some don't, some like small, some like larger. The physical neutrality is certainly important, but the effectiveness is variable, and we need to understand that variability. And with future understanding of their individual cellular responses, it'll be a lot easier and a lot more precise to make these decisions. So thank you very much for your attention.
Lawrence, that was amazing. Thank you so much for that comprehensive review of everything that's happening in spinal cord stimulation. Before you turn off your video and you go away, I actually have a question for you. And I encourage the audience to enter the questions for you into the chat group as well. With all these new technologies and different spinal cord stimulators coming on the market, how do you make a choice for your patient population as they come in and they seem to be a good candidate for SCS?
So if they're a good candidate for SCS, then the question is, what are the characteristics of their pain, and what are the individual characteristics of the patient? I get a fair number of patients that are trialed by some of my colleagues who don't do implants. And it's actually not that uncommon that they'll say, yeah, this worked great, I loved it, I want to implant it. And then when I start telling them about the particular characteristics of that device, they're shocked to say they don't want it. So they may say, oh, I'm too busy to do recharging every day, I don't want to do that. Or they might say, I wear bikinis and I don't like that big thing bulging, I want something smaller. So every patient is different. We certainly look at our clinical data, but the clinical data is coming out so rapidly that it's critical that we evaluate that very closely and understand at least every few months new data coming out. We need to assess that in that SAFE principle. So once again, every single time I do a case with a fellow, we have to go through those SAFE principles. Two patients with the exact same condition may not end up with the same device. It all depends on the other characteristics that are important to that patient.
Excellent. Thank you so much. And please stand by. I'm sure there's going to be a lot of questions for you at the end of the webinar.
Sure.
With that, we're going to go to my friend, Dr. Krishnan Chakravarti from UCSD. Krishnan has already taught so many people, so many fellows and physicians all around the world about various modes of spinal cord stimulation, including DRG. Tonight, he's going to talk to us about dorsal ganglion stimulation. Krishnan, the floor is yours.
Thanks. Thanks, Kaz. Thanks, the rest of PSPS, and thank you to Lawrence. It's always listening to him put together a talk in 30 minutes covering all of STIM can always be challenging. But for all the fellows out there tonight, and I think most of you share the same sentiments that I always get to when I'm teaching my fellows is, you know, probably 10, 15 years ago, we would have had a lot fewer choices, and the amount of information that we would need to learn and understand has a lot less. And today, if you take a look at the amount of content and science that's driving this field, it's an absolutely amazing time to be in the field, but really provides the onus and responsibility on all of us to try to learn as much of this as we can. And I think the challenge that Lawrence and I think Kaz kind of really alluded to is the next 4 or 5 years that we're going to be in this field is really getting down to how do we take what we understand from mechanism and translate and apply that clinically. And that decision goes in every time we see a patient, every time we decide what device to use, what makes sense, what does the data say, is it contradictory, is it supportive? And so I encourage all of you that, you know, in a 15-20 minute effort, it's just a snapshot, but really take the time to look at a lot of the foundation of a lot of these therapies that have come across. So I'm going to cover DRG today, which we can go to the next slide. I think, you know, when you look at my own experiences, I've had a, you know, I put the slide up really to articulate one really important point, which is most of the faculty today will tell you that when you talk about home run therapies, this is the one area that you can really see significant change. So I had actually a patient that I recently had done about 6 months to a year ago that had phantom limb pain for the last 18 years. And we had tried everything pharmacologic. We'd even tried conventional stim. And at the end of the day, we had placed 2 DRG leads on 2 levels that, I mean, absolutely life-changing for him. Why I bring that up is I think a lot of DRG, it's a more complex therapy to train on. It's a more complex therapy to deliver to our patients. But when you have the right patient selection, especially with folks that have really intractable CRPS and or cases that you know that have really had not much result to pharmacologic and or other type of focused interventions, you can really see a dramatic effect. And I think part of the next 5-10 minutes I'm really going to cover is why do we really see that dramatic effect? And that's really to do with an understanding of how the therapy was actually discovered originally at Stanford in the West Coast, and really the foundation of the science that leads to a lot of its clinical utility today. Next slide. So, you know, I think it's fascinating. You talk about the mechanism of action of STIM, and to a large part, we keep referring to gate control theory and how critical it is from sensory perception from the peripheral nerve always going to the cortex and vice versa, the kind of the ascending descending inhibition. But the reality is that I think if you look at the literature, and I think Lawrence was alluding to some of the work that now Adnan is pursuing, looking at macrophages, started looking at DTM therapy, looking at a lot of the existing work, looking at profiling cytokines. The reality is we are only starting to understand how complex the system of our biological tissue is when we put electrical current to it. When we think about stimulation as just simply affecting neurons, there are a whole host of different cells that have played a critical role, and the expectation that current doesn't necessarily affect that is a misnomer. It's really the point where we're starting to understand mechanism that's beyond just stimulating a neuron and looking at action potentials, but what does it have in terms of the surrounding microenvironment? Next slide. So this actually, Elliot Crames published this in 2014, and a lot of the same principles you're going to see pretty consistent among the spinal cord literature that I think will be dominating the next 2 to 3 years at least, which is really asking the critical question about what is happening to all of these different receptors, what are happening to different channels, what are happening to specific cytokines and chemokines. So things like tumor growth factor beta, IL-1 beta, TNF alpha, the things that we always think about in high school biology and or medical school, we really started to ask those questions, because the reality is that, and I've spoken a few times about this, if we don't think about isolated effects of current, and we really think about the effect on a huger microenvironment when we create these kind of electrical fields, then we're really going to start to understand the more important questions that are facing our patients. Is how do these mechanisms really relate to failure to therapy and certain tolerance that happens at 3 to 5 years? And are we really getting to the aspect of measuring specific growth factors and biological parameters that help us determine who's the ideal candidate for one stimulation versus another, or one system versus another? Next slide. So one of the, I think when you saw that first slide, for most folks, I think one critical element that a lot of people forget with a lot of the DRG stimulation literature and like the basis behind it, is that with specifically complex regional pain syndrome, we know it's an excessively sympathetic driven response, right? So you see the classic definition of that when you're thinking about the Budapest criteria that we constantly apply and that is being modified in our clinic. So you see the swelling, the temperature changes. But the reality was that when they first looked at a lot of the effects of stimulation on the DRG, what they really found was that instead of just simply looking at the effects of stimulation on changes in different fiber type transmission, DRG was really the first therapy that really showed a direct effect on sympathetic activity. Why is that important? Because sometimes, to some extent, that definition of mechanistic effect on sympathetic activity is what correlates to the clinical outcomes that you're observing, where you see a significant reduction in swelling or a significant reduction in the classic symptoms that we think about with CRPS, such as allodynia, and certainly the kind of long-term, short-term benefits that we had thought always with CRPS, which was looking at LSB blocks with rapid onset physical therapy. So I think from that perspective, when we think about mechanisms for DRG, we must be mindful that there's also a lot of evidence that it really is a combination of both looking at changes in action potential firing in the DRG, but really having a more broader, consistent effect on sympathetic activity modulation. Next slide. So how does that really, what is the basis and the rationale for that? So the reality is you have to look at the anatomy of the DRG. And it's unlike any other part of the nervous system in the spinal cord. It actually functions where you have what are called cell bodies with a T junction. And typically, when you think about most cell bodies and axons, they don't have what are called unipolar, pseudo-unipolar cell bodies, which means that they have two parallel axons connected to a central root. Next slide. So what that effectively means is that the T junction plays a critical role in the propagation of different action potentials in the DRG. That's very different than if you were thinking about the dorsal horn or the dorsal column. And so three specific effects happen to any action potential that goes to the DRG, right? One, you get complete abrogation of that action potential. Two, you get a diminishing effect of that action potential, so looking at less frequency. And three, you actually get changes in the amplitude of that action potential. Next slide. So what they had done is the initial actual testing around this is they were looking at what are called patch clamp technique, which is actually inserting a single electrode into the membrane of these different soma bodies or single T-junction pseudopolar unit neurons to really see the effect of electrical current changes on stimulation. So when they looked at these axonal stimulations, what they saw at baseline to after stimulation was a significant reduction. So what was really happening was that the T-pass junction was really acting as a suggested filter for action potential propagation. Next slide. And so when you started to record the actual electrical current and the neuronal response, what you're observing is that on electrical stimulation, you had complete abrogation of that response. So this was the first kind of real solid evidence that you could actually stimulate the DRG to shut down the number of action potentials propagating through. Next slide. So the other part of this that's interesting was that if you look at now what we define as chronic pain sensitivity, so you think about hyperexcitable states, what really they were finding is that the DRG, by in fact, on patients that had really the definition of chronic pain that we think about at transitioning from acute to chronic state at anywhere greater than 3 months, their DRG were hyperexcitable, which means that their ectopic discharge, the amount of action potential that was required with electrical current to change the stimulation, was a lot less. So it's interesting. One of my close colleagues, who I consider as a mentor, is Tony Yaksh. And in fact, he had done a lot of the initial work on drug pharmacology, really looking at the effects of different cells and different cell types migrating to the DRG. So in fact, a lot of the pharmacological world really looks at the effects of the different drug targets that we think about inflammation oriented, looking at what the effect on the sensory and ectopic discharges in the DRG are. Next slide. So the other part of this is really to understand the organization. So why is that important? Because from a clinical utility and a clinical application, how the patient presents will really help you understand the dermatomal targets that you want to use in terms of placing the leads to get a desired improvement in pain. So if we can advance that. So obviously these dermatomes correspond to specific pain, right? So abdomen and groin in your T12, L1 your hip, waist, and groin. So each of these, you really want to be mindful that when you're looking at a patient that you're working up for a possible DRG implantation, really correlating the dermatome to the anatomy that you want to target. Next slide. So the other part of this is I think is really interesting. When we do our trials, you hear a lot of the folks that are faculty experts that have been doing a lot of cases that really say there's some component of convergence and divergence related to DRG. What does that really mean in a practical sense? That means that the reality is if you're having difficulty looking at a single dermatome, that there is some consistency that suggests that the science and literature that you may be able to target a dermatome above or below. So I'll give a really good analogy that was a beautiful study that was done in Nature recently. They were looking at a CIPN model, and what was really fascinating about that is that the patients that had antibiotic treatment, and I've given this analogy and example before, but it really illustrates the consistency in the science, is that they in fact had less development of actual CIPN. So you would be thinking, well, what does antibiotics have anything to do with chemotherapy-induced peripheral neuropathy? But the reality of what they were finding is a beautiful mechanism and a beautiful story that was laid out was that the gut microbe in your gut actually would present the cisplatin drug to microglial cells that would traffic to ultimately their end destination in the DRG. And so in nature, in its consistency and in its effective intelligence, realized if inflammation and the way the body actually deals with infection, you don't ever want to be able to fight infection only at one specific location, because you want to be smart enough to create a lot of redundancy. So what was happening was in that beautiful case study, what they were finding is that these DRG, the microglial cells, wouldn't just traffic to specific dermatomes, it would actually redundantly traffic to the DRG above and below the area that it was targeting. So in a way, to create some kind of way for the body to consistently fight, in this case, in the right sense, infection, but in the wrong sense, in this case, a redundancy in the cisplatin being a chronic inflammatory nidus. So they, in the 90s, 60s, and 70s, they really did a lot of the ganglionectomies that proved this, that there is a lot of these convergent and divergent pathways. So then from a clinical perspective, when we're looking at the actual application of the stimulation, we can be mindful that you have the ability to stretch a level above or below, and certainly the impact of that stimulation may actually affect multiple dermatomes. Next slide. So from a patient selection standpoint, think about where is the injury. Obviously, injury can be secondary to trauma, it can be post-surgical, it can be a peripheral nerve injury, it can be chemical, but really looking at where is the pain and targeting the specific dermatomal nerve roots with the concept of convergence and divergence, but certainly being mindful that certain parts of those dermatomes are more appropriate for specific indications and targets. Next slide. Next slide. So just being mindful, I think when we're trying to decide really what is the appropriate target, this is a great resource that over 50, 60 clinicians put together. I mean, I think it's really a fantastic way to kind of see what have people trialed for different types of pain, and certainly seeing when kind of the most appropriate dermatomal location is for a specific type of pain that you're targeting. Next slide. So one of the questions that Lawrence had asked me to address was, can traditional stimulation work just as well? Look, and this is where I think where we have to be mindful of what deliver and the thought process and the scientific process that came to the discovery of a therapy. So what Dr. Poré had told you was, interestingly, that the reality and the thought process for why somebody was thinking about DRG in the first place was to avoid as much CSF in relation to what you're stimulating. So if you take down at the end of the day, basic of what is neuromodulation, it's really creating an electrical field that is targeting a specific tissue or a biological end output, whether it's neurons, whether it's glial cells, whether it's the entire microenvironment that's getting affected in that field. So the original idea with the whole DRG as a science was really to get these leads to create an electrical field that's optimized to a elliptical and biological target. So in my mind, at the end of the day, does it really make sense to place a traditional stimulator to get a lot of the stimulation across, or these fields to really get to the DRG target? It may or may not work, but the point is, from a rational sense, from a clinical and a scientific perspective, the net idea is I want to minimize the amount of CSF that's in contact to where I want the stimulation to go. Why? Because CSF is a highly conductive material, right? So it has natural propensity for electrolytes and ions that disperse the electrical field. So if I can actually place the lead closer to my target site, and I can create the same effective electrical field, then I can use a lot less energy to deliver the same end clinical effect. So when we talk about having that conversation, the balance from the clinical perspective is the decision: does ease of implantation outweigh the scientific merits of placing necessarily a lead at a more targeted site for the end clinical outcome, which is you're affecting the actual microenvironment within the DRG. Next slide. So just really quickly, what does the most recent clinical data show? Next slide. So obviously everyone should know the ACCURATE study. It was 152 subject, 1:1 randomized DRG versus control, and looking at up to 12 months. Next slide. That obviously showed superiority of DRG over traditional spinal cord stimulation in both in terms of pain relief, functionality, as well as preference. Next slide. So this actually was just recently published by a group of folks that looked at a pooled analysis, which was just really the overall data across multiple studies. And the key take home obviously is, again, consistency among changes in pain score as well as function. Next slide. And so I'll wrap up with what's in the future. Next slide. So this actually was a recent study that a good friend of mine, Dr. Kinfa out in Germany, Tom, as well as some of the folks that you recognize here, started to really look at transcriptosome profiling. So I think why I bring the slide up is it's not just a simple assessment of when do you collect a lot of these biological markers. You look at the time frame when you collect it, how long you're stimulating, what medium are you collecting it, whether it's CSF, whether it's whole blood. All of these factors put together are things that we're going to have to work out. But the point in this study, and I think it's an interesting aspect of how we bring the science to a clinical support, is when we started to look at all of these changes in inflammatory markers. So I started this whole conversation talking about how I felt DRG was a critical part of the mechanism is the sympathectomy response that you're seeing, but certainly the effects on different inflammatory cells. We are now starting to really look at the transcription of all of these different inflammatory mediators, and what we're observing is there's a significant change in the genetic expression of all of these different mediators in that environment. Next slide. And of course, the other area that is really asking, are we looking at what are other folks specifically studying? This was actually done by folks in, I think, Japan or China that are looking at ultra high frequency, 500,000 hertz pulsing within the DRG to see whether there's any perceived benefit. Obviously, very early data, lots to be worked out, but the point is these are the types of different research that people are focusing on, not just the effects on the changes in the microenvironment, but how does the current being delivered at the DRG make an impact on patients. Next slide. So that's the last of it, and looking forward to my close friend and colleague Jackie talking about the actual implementation of the therapy.
Krishna, that was amazing. Thank you so much. There's, you know, as you may recall, I was an investigator in the ACURATE study, and it seems to me that the science has advanced quite a bit. I do have a question for you before we go to Samir. You know, as you know, the ACURATE study, we studied CRPS1 and CRPS2. With all the new information about DRG, what are the other indications that you're excited about as it pertains to DRG?
Yeah, you know, that's a great question. Look, I think we as pain physicians are at a critical junction, and I'll tell you why. Because there's very little in the world of pharmacology today. Primary care physicians may be at the front end of treating rheumatoid arthritis or things that we think about as CIPN or small fiber neuropathy, where there's a clear chronic inflammatory underpinning. As we see the price and adoption of neuromodulation becoming much more global in terms of getting out of the interventional pain physicians or making it more easily trained, I think therapies like this are going to see themselves outside of the pain field. So something like rheumatoid arthritis, where there's a huge investment, or whether we start to define chronic inflammation in a lot of the different pain modalities or pain pathologies, and once you've defined that, then you can tie your mechanism to what you're treating. And I think we've always been trying to chase the mechanism after clinical utility. I'm hoping that we will see a paradigm shift where once we understand the disease process, then you actually tailor the therapy to it. So I think we're going to see a huge explosion in types of uses for neuromodulation, but I think chronic inflammation is a really interesting area that we're going to see a lot of growth.
That sounds really exciting. Thank you so much, Krish. And please stand by. I'm sure the audience will have a lot of questions for you afterwards. Now we're moving to the last, but probably one of the most important sections of the didactic portion of our webinar. Samir Sheth, I mistakenly said from UC Davis. I actually got to know him when he was at UC Davis. Now he is at Sutter, and he's among us, the private practitioners, and he's going to talk to us about the NAC guideline reviews and management of complications. Samir, the floor is yours.
Thank you, Kaz. I really appreciate it. And I have the pleasure, I guess, of following Dr. Pore and Dr. Chakravorty, which is not an easy task, but I really thank them, and I was really impressed with their talks as always. So just want to thank them and probably stay a little bit longer. Our talks have gone over a little bit, but I think that's worth the time. So here are my disclosures. I have no financial relationships to disclose. So briefly, I'll be talking about the guidelines that were released in 2017, and it's really, they were labeled the Neurostimulation Appropriateness Consensus Committee recommendations. And there are 4 different papers that came out in 2016, 17, really focusing on infection, neurological injury, anticoagulation, and one that Dr. Chakravorty just reviewed was the dorsal root ganglion recommendations as well. But today I'll be focusing mainly on infection and briefly review neurological injury and anticoagulation. Next slide, please. So really quickly, again, just looking at how these recommendations and consensus statements were made, they were made based on the U.S. Preventive Task Force Services Task Force guidelines. So looked at the evidence, the degree of the recommendation, and then also a third step was to look at a consensus statement of all the excellent authors that were involved in the study in developing these recommendations. Next slide. So really, let's focus in on infection right away. And, one thing that really struck me on these talks was that the technology that we have is quite amazing. And really, there's a lot of opportunity for our patients to have a good therapy that will last for years, especially now with the recent research that we have. Unfortunately, what we need to recognize is that infection can make all of that irrelevant, and any sort of complication, significant complication, will make all of that irrelevant. So we need to be very mindful of the fact that we have a fairly high infection rate for our implants, and though we've taken some great steps to reduce it, is still something that we need to be very mindful of. So as you see, historically the rates have been of anywhere from 1 to 10%, but recently the most recent studies have shown about 2 to 3%. And so in addition to the issues, obviously, to the patient, the cost of infection management is quite significant as well. So even a modest reduction in surgical site infections can lead to significant cost savings for all of us. Next slide, please. So there are 3 types of infections, so we need to identify what they are. So they're superficial, deep, and epidural abscess. So superficial is affecting the subcutaneous layers, whereas the deep is affecting the muscle layers and the fascial layers. Usually there's a 30-day reporting period for superficial, but when we look at it, most commonly, a lot of these infections tend to go deeper, and it tends to affect the pocket site most commonly. And usually the infections present after 1 or 2 months. The most common infectious organism that's been isolated is Staphylococcus species, followed by E. coli, and then Pseudomonas. Next slide, please. So, as much as we'd like to think that our patients don't look like this, the reality is in a chronic pain population, we do have many patients that are pure in this way. So our job, our task, is to try to reduce infection for people like this. Next slide. So what can we do? We can look at a lot of different things. Obviously, looking at the home environment, if they're somebody that, obviously is in an unhealthy home environment, we have to look to modify that. Look at their infection history. Does somebody have a lot of infections, and why do they have those infections? An important point here is patients that present with either they may be a transplant patient, HIV, or cancer patients. There's not a contraindication to doing these patients, but in fact, I think many of these patients, I just did one this week, have horrible neuropathic pain and are very good candidates for neuromodulation. I really just strongly feel that we need to have a very good conversation. So it's a strong indication to speak to the specialists that are also taking care of these patients. So really a very careful shared risk assessment when treating these patients with immunodeficiency. Looking at diabetes, smoking, and steroid use, individually, those all increase the risk of postoperative infection. So specifically, diabetes, really trying to minimize and optimize their A1C prior to the surgery. Also looking at minimizing hyperglycemia in the immediate perioperative period. Smoking, an optimum time to quit is approximately 4 weeks prior to the trial and implant. And those, if we're able to do that, that can lead to significant reduction in infection, and also limiting steroid use immediately prior to any sort of trial or implant can reduce infection. Next slide, thank you. So if somebody has, I like to see my patients about a week before their implant, and if I'm able to, just try to ask them any sort of soft signs for if they have any increase in urinary frequency or any other cough or cold, and really just be hypervigilant for these patients, and maybe get a urinalysis, especially if they are complaining of any symptoms for those patients, or a chest x-ray. Another really important point that kind of Dave Provenzano really spent a lot of time with as well is looking at the MSSA carriers and MRSA carriers and trying to do decolonization. So understanding that Staph aureus species are responsible for the vast majority of our infections, and also understanding that approximately 25 to 30% of the general population is colonized with Staph aureus. If we're able to identify these patients and then decolonize them with mupirocin nasal ointment and a chlorhexidine bath, that can also lead to significant reduction in infections. There is no empiric kind of treatment at this time. It's really try to identify these patients via nasal swabs and then treating appropriately if they are positive. Next slide, please. So intraoperative measures, next slide, please. So one of the most, One of the most important things to recognize is that antibiotics in the perioperative period, in this case, immediately prior to the surgery, is very important. So not only are we making sure that we're selecting the appropriate antibiotics, but also weight-based antibiotics is going to be very important for our patients. And really speaking to the anesthesiologist involved with the implant to make sure that it's given appropriately within the proper time interval. So, with cefazolin and clindamycin within 30 to 60 minutes, whereas with vancomycin about 120 minutes prior. And again, remembering, just emphasizing the weight-based dosing to ensure that you have appropriate minimum, the MIC, the minimum inhibitory concentration to stave off the bacteria. Next slide, please. So other things that we can do, I'll skip through a lot of these quick, but shaving hair with electric clippers immediately before as opposed to the night before. Scrubbing, appropriate scrub, we all know this, and then also making sure that we use an appropriate prep for the patient. So our chlorhexidine soap has been found to be superior to povidone iodine in terms of its range of activity against gram-positive, gram-negative, as well as yeast and mold, but also it's not neutralized by organic compounds as povidone iodine is. I also, for my patients, I give them a chlorhexidine soap to wash in 2 days before, so 2 nights before, the night before, and the morning of any trial or implant. So that's something that's not discussed in the NAC, but I just wanted to say that I do that for my patients as well. A sterile prep, obviously, in a double glove. It's important, and I think Dr. Nadu might speak to this later in his practice, but maybe switching the glove prior to handling the battery might be also a nice way to reduce the amount of infection or reduce the amount of bacteria on that glove prior to handling the implant. Next slide, please. So intraoperative measures, again, what we think of the operating room as a sterile and very, very sterile environment. There's bacteria everywhere as well, despite it being considered sterile. So studies have shown that light handles and C-arm handles have, the C-arm, I should say, have higher bacterial counts than other objects in the room. So really trying to minimize that, or directing surgical techs or other people in the room to help move those when necessary. Limiting people in and out of the room is also very important. Next slide, please. If we can make incisions as small as possible, minimize electrocautery, and then really what's been found to be very important is limiting surgical time. So that has been shown to decrease the amount of surgical site infections as well, and that kind of leads to my next point on the next slide. So when we look at what the NAC did recommend was making sure that people who are implanting neuromodulation systems have at least 10 cases of experience. So we realize that not everyone might get that experience in their fellowship, or people may want to learn about neuromodulation later on when they didn't have it earlier on in their careers. And so, it's really important to get proctored by somebody with experience to ensure that you're doing this properly and that we have good outcomes. Other things that we can look at that we tend to do is wound irrigation. So making sure we have copious wound irrigation, understanding that you don't necessarily need to put anything in the irrigation. Bacitracin specifically has been shown to cause resistance as well as cause tissue toxicity. So it can impair wound healing. Some surgical literature does suggest betadine irrigation, or povidone iodine irrigation, I should say, can be effective. So I definitely have been using that. And then I think what's debatable, I guess, or in trendy right now, is looking at vancomycin powder. And there is quite a bit of surgical literature to support vancomycin powder in the wounds prior to closure. However, I think it's still, at the time of the NAC publication in 2017, there is still not enough evidence to recommend it. We'll see what happens in the next NAC, but I do think that this is something to watch out for. Personally, I do it, but I think it's something that there's still some evidence that we really need to look out for, and look out for outcomes, negative outcomes for people who use vancomycin powder. Next slide, please. So, other things that we can look at are using in the high-risk patients for trials, using a biopatch, and also for implants, maybe using even an antimicrobial envelope around the implantable pulse generator may reduce infection, but not necessarily for all patients. And then also what's really important to recognize is no antibiotics after 24 hours. So there are, I think, a lot of people who are still using antibiotics for longer periods of time. understand that that is not associated with decreased risk of infection, but in fact is associated with resistance as well as associated with other complications like abdominal pain and potentially even can lead to C. diff colitis. Next slide, please. Next slide. So other things that we can do post-operative measures include removing occlusive dressing within 2 days, making sure that staples and non-absorbable sutures should be taken out within 10 to 14 days, and really just hypervigilance here, right? So just making sure that when you're seeing your patients, if you think that there's any sort of infection, even the slightest bit, to make sure that you have close follow-up with them and to make sure that you get the appropriate labs in case just for follow-up. So the most important one that I would recommend is the CRP, and the NAC recommends CRP, as well as making sure that you get appropriate imaging. If you feel like the pocket site has a little bit too much edema, maybe getting an ultrasound, and if necessary, an MRI. Again, it's just close follow-up because we don't want it to get worse, right? It can lead to an epidural abscess, and that's associated with significant morbidity and mortality. Next slide, please. Really quickly, understanding that, that's perfect right there, understanding that what we think of as typical infection doesn't necessarily always present with our implant patients. So I just really wanted to call your attention to table 1, and that most commonly the main sign or symptom is pain, but fever doesn't necessarily occur all the time. In fact, in this study, only in 17% of patients did it occur. I'm sorry, 26% of patients did it occur. So really being mindful of these patients in the postoperative period is really, really important. Next slide. And then also they are very hard to manage. So oftentimes it leads to system explant. Next slide, please. So shifting gears here to neurological injury. So it's important to recognize that neurological injury can result from a lot of different factors, including direct trauma, infection, and bleeding. I already covered infection, and I'll cover bleeding in a second. But neurological injury can occur during, so needle placement, like I just said, lead manipulation, like so during the trial, if there's a lot of movement of the lead and trying to get that lead up there. And also remember, lead removal can also lead to neurological injury. The risk of neurological injury is low, but not negligible. So about 2.35% percutaneous and 1.71% for paddle placement. And this was in a large retrospective study that they looked at this. The incidence of spinal hematoma is not negligible either. It's 0.71%. So I'm understanding that these are just what's reported as well. Next slide. One of the things that we need to recognize, and what we've seen in closed claims database as well, is that many of the injuries that do occur to our patients, neurological injuries that do occur, are in patients who are deeply sedated. So, and many of our patients are, especially for STIM trials, because it is something that is very invasive and can be quite painful. So we might over sedate them, if we will, and that's something that has been associated with increased risk of neurological injury. So understanding that if you are going to use a deep MAC, or if you're going to use general anesthesia without monitoring, it can be quite risky and increase the risk of infection. So the NAC did recommend in 2017 the use, highly should consider, I should say, the use of intraoperative monitoring for patients who are receiving a deep MAC or with general anesthesia. And there's been multiple studies recently to support that as well. Other things that can occur include dural puncture and post-dural puncture headache, and though they're not that common, about less than 1%, unfortunately, there are no clear recommendations at this time on what to do if you do get a dural puncture. I think it's just a case-by-case basis. Current guidance does not advocate for prophylactic epidural blood patch just because the blood products can lead to infection as well. Next slide. So in summary, in order to reduce neurological injury, what we're looking at is trying to optimize anticoagulation, which I'll talk about briefly on the next kind of couple minutes. Follow NAC guidelines for infection control, and remember that sedation practices, we want to avoid keeping our patients too deeply sedated, and if we are going to deeply sedate them and use general anesthesia, consider intraoperative monitoring. This next bullet point, I know it seems silly, but I think it's really important, understanding that if there is significant stenosis at the level that you're going and using and kind of having your lead go traverse, I should say, that can be associated with significant complications as well. So making sure that you're familiar with the images, reading the images on your own, understanding appropriate amount, having enough space for the lead that's going in. Next slide, please. So in one slide, I'm going to go over anticoagulation and understand aspirin probably is the most important or most common one that we see. So for spinal cord stimulation trials and any intrathecal trials, these are high-risk procedures, so we want to be very careful. The primary prevention, you can safely hold these patients for 6 days. Secondary prevention is anybody who's had a stroke or a heart attack, and according to the Zisman paper in 2010, we can safely hold these for 4 days. And again, we have to do this with a shared risk assessment. NSAIDs offer no benefit there for any therapeutic benefit. So I just tell my patients who are on NSAIDs to hold for 7 days if possible. But if we want to be very careful and look at the studies, we want to look at the amount of half-lives that they need to and hold it for 5 half-lives. You don't need to hold COX-2 for your trials or implants. Understanding that there are a lot of newer anticoagulants available. So looking at taking the time to look at the half-lives of these medications and understanding of whether or not they're renally excreted is also important. Again, you want to hold it for 5 half-lives unless there's significant renal impairment. So when to restart? If you have a patient that is on a blood thinning medication and they're having a trial, you might want to shorten the duration of the trial because you don't want to pull the leads while the patient has restarted any of his his or her blood thinning medication. So in those cases where there's a high risk to the patient of being off the blood thinning medication, you might want to shorten the trial and then restart the medication 24 hours after the lead removal. And for an implant, it's the same thing, 24 hours after the implant. I highly recommend the ASRA application. It's ASRA Coags and it's updated constantly. So I think that's another really good thing to do. Finally, shared risk assessment as much as possible whenever you can, or not much as possible all the time. You want to make sure that you have everybody on the same page. Next slide. So in conclusion, you know, the NAC guidelines are excellent, comprehensive, and should be followed whenever possible. Remember, most of us can do these procedures. It's just a matter of how we manage our complications that really make us and define us to be better physicians and providers. So just keep that in mind, and thank you again for your attention.
Excellent, Samir. Thank you so much for that. And by far, one of the most important portions of this webinar. I do have a question for you. You know, we talked about getting wet taps, you know, during a trial or a permanent implant, and you said that there's no specific guideline for that. What do you do in your practice? Just really quick.
Yeah, so I think if it depends on the age of the patient. So if it's a younger patient during a trial, I might come back another day because it might affect younger patients or tend to have more commonly will present with a post-dural puncture headache. But if they're older patients, I might go ahead and proceed. For an implant, I tend to just proceed. I think it's safer and I'll manage the complications as they arise in the postoperative period.
I agree with you 100%. That's exactly the way I handle it. Thank you so much, and please stand by. Hopefully we'll have some time at the end to answer some questions, but we may be running a little bit long, so we'll see. But thanks again for your presentation.
Thank you so much.
This takes us to the video portion of the implants. So my part is a trial. Next slide, please. These are my disclosures. Next slide, please. As a lot of you know, I've been doing this now for about 20 years. So when I did my first trial, it took me about 3.5 hours to do it. And now, you know, it takes me about 15 minutes to get it done. It's a process, and yeah, the more consistent you are with the way you do the trials, the better you get. That's not to say that complications don't happen to me, but they can happen to anyone at any time. But with a consistent procedure, the risk of complications is a lot less. Can we start the video, please? All right, so that's me. It is not Brad Pitt. I'm just showing my target at this point. I've tilted the C-arm to line up the end plate at my target area where I want to go into the epidural space. In a normal patient, we typically start medial to the pedicle below and take a very shallow trajectory to the midline in order for us to be able to enter the needle right into the epidural space like that. So if you follow the same procedure every single time, the consistency sort of plays into the way the operating room procedures go for you. So at this point, I'm just designating exactly where I would put the local anesthetic on a patient, medial to the pedicle below. I'm going to go ahead and grab the 14 gauge needle. Typically in a live patient, I use a 22 gauge 3.5-inch spinal first, and I'll take it down to the lamina. And as I'm pulling the needle out, I usually put some local anesthetic in the soft tissue. In a cadaver, obviously that's not necessary. I'm taking a very shallow angle, no more than 30 degrees to the midline. As I'm getting past the laminar border, I take the stylet out and I use the loss of resistance syringe to advance the needle right into the epidural space. Ideally, I would love the tip of my needle to end up right at the midline. So I always use two hands as I advance this, the needle. That really reduces the risk of getting a wet tap. The needle is in place, we got loss of resistance, and I'm now introducing the lead. I typically pull the stylet back ever so slightly as I introduce the lead into the epidural space, just to ensure the fact that I'm not going to poke the dura. I have the, and you can see how shallow the needle is right to the midline, and the lead is following right into the midline. So regardless of the kind of dorsal column stimulator that you're using, if you start at the midline, you can potentially deviate the lead to the right or to the left as you need it. With this particular brand, we only place the lead at the anatomical midline, so I'm actually pushing the lead up to get it to the top of T8, which is where the first lead is placed with this particular brand. I'm slowly using low dose fluoroscopy and pushing the lead up to the T8 level. And once the first lead is in place, just like that, I usually take my time in order to make sure that it steers into place without too many issues. And that looks pretty good. It looks like we're almost done with that one. And I just have the fluoroscope follow me while protecting my hands by keeping them outside of the fluoro image itself. It's really important to know that I try to keep the lead really straight. I try not to curve it because part of the steering mechanism can potentially torque into that, and you may not have as much steering mechanism. I always place my leads ipsilateral. I've already made a skin wheel. I've already localized the track, and I already know how that first needle behaved. So the second needle typically follows the first needle without any issues and falls into place. The second needle goes far faster because of this strategy. So 100% of my trials and permanent implants are now ipsilateral needle placements, unless there's an issue with the first needle. So as you can see, the second needle is in place. They're diverging on the outside, but the tips of the needles are converging and almost kissing within the epidural space. Loss of resistance, the lead is being introduced. Again, taking the lead up to the anatomical midline very slowly. And for this particular brand, the second lead goes to the mid body of T9, and that's a typical placement for low back and leg pain spinal cord stimulation. So we stagger the contacts just to make sure that we can cover as much surface area for some micro programming if it's necessary. And that lead placement looks pretty good to me. And at this point, you can see the first lead is at the top of T8. The second lead is in the mid body of T9. And we just need to get a lateral to make sure that the leads are in fact placed in the dorsal epidural space. Now, even with 20 years of experience, the leads could potentially go ventral from time to time. So it's incredibly important for everyone to get a lateral. It only takes 3 seconds to do so, and that typically shows us where we are. So there's no positive pressure within the CSF, and that's the reason why the leads don't look like they're at on different planes. But I assure you they're both dorsal at this point, and they look perfect the way they're placed. So once we have this, we just go back to the AP view, and we can start taking the needles out. So we typically connect the connectors to check impedance on the device to make sure that all contacts are in fact functional, so the patient can have the best trial experience possible. So once the connectors are connected, the cables are passed to the company representative where the impedance is checked and confirmed, and then the connectors are disconnected like that. I make sure that the stylet is going through the needle. It doesn't necessarily need to be all through the lead itself. And I twist the needles as I pull them out in order to reduce the friction coefficient on the lead itself. So, and by doing that, inadvertently, the leads typically move up ever so slightly, but that's never an issue. You can always move them down. Even if the lead moves down for whatever reason, it is not a problem. We can potentially just push the lead back up because they're still sterile, and the stylet can help you do that. The needle and the stylet both come out at the same time. The second process happens for the second lead as well. So the needle comes out and the stylet comes out all together. Typically, I throw a chest tube tie suture onto the skin to secure the leads in place, and then that is cut at the end. So I usually use O-silk suture to do so. I'm just going to do a couple of loose knots at the skin surface, and the loose knots need to be loose enough for me to be able to get an instrument underneath them. And once the loose knots are done, I take the suture around the lead once or twice, like a chest tube tie. And the chest tube tie is almost a woven suture around the lead itself that acts like a Chinese finger trap. So now the lead is nice and secure, but it's loose enough that the body dynamic movements don't necessarily put too much strain on the leads themselves, and that reduces lead migration. In fact, in slender patients, when I don't use an anchor within the soft tissue itself after my dissection, I still use a chest tube tie on those patients as well. Once the suture is done, I reconnect the cables. For the upper lead, I usually put a knot in the cable just to designate it for the representative. I put Mastisol on the skin, put relief loops of the leads onto the skin, and just like that. And then I take it around and I put the entire apparatus under the dressing because I don't want the connectors and the leads to separate. This is mainly because of the fact that patients only get one chance to do these trials. And the last thing I want is for the leads to separate from the connectors and for the patient to have a bad trial experience. I want to give them the best chance possible. And that's pretty much the end of the trial itself. So with that, I would appreciate it if you load the next one, which is the permanent spinal cord stimulator implant by none other than Dr. Rama Naidu. Ramo, the floor is yours. Show us how it's done.
Oh my goodness, thank you, Kaz. So in the same amount of time, I'm going to do an implant. Welcome everybody. It's great to see all of you, even though I can't really see you. I'm going to go through an implant. If you go to the next slide, Stephanie, before we get started, I do want to say, you know, I've had the privilege over 9 years of using every single spinal cord stimulator company that's commercially available. And I'm just showing you one particular company. But there are many principles that apply to all the products. Of course, they all have their own bells and whistles, and we'll go through some of that today. In this particular implant that I'm going to show you here, we did a trial and we found out that this particular patient's ideal sweet spot for stimulation using the contour algorithm was right at the inferior aspect of T9. So Stephanie, let's get started and we'll get going. All right, so the first thing I do is, just like Kaz was doing, is I mark that needle insertion site at the pedicle, but I'm gonna make my incision prior to actually placing any needles. And usually the length of this incision, which is what I draw following the pedicles on the same side, on the ipsilateral side, usually is about 3 centimeters. Now it might be a little bit larger for a much larger individual so that I can see deeper into that anchor site. But this gives me a nice length in which for me to put 2 anchors and the leads and the tension relief loop. We can see I'm doing there is creating a shelf, and that's going to be where my tension relief loop actually sits. So here's my 14 gauge TUI, very similar to what you've seen with Kaz. Touch lamina here. Now I skive off. Usually when I touch the lamina, I use a little local anesthesia because that's usually one of the most stimulating parts of the TUI placements. Again, nothing too complicated here as far as the use of an LOR syringe. I use 2 hands. I use continuous pressure, and I can generally sense when I'm getting the ligamentum flavum. This particular cadaver had a very taut ligamentum flavum, so I could feel that, and then boom, I'm in. So I felt the pressure kind of increase, did a couple pulses, and knew that I was there. So we used 2 octrodes here for the trial. We used a 16 contact lead, but in this case, since we knew where we needed to go, we were using 2 octrodes. So threaded that up here. Now in a cadaver, obviously the epidural space is quite patent because there's no CSF pressure. So you can see it's steering quite floppily. Whereas in the real world, in a real patient, of course, it doesn't flop so much. But nonetheless, we're getting the tip to the T8 inferior end plate, as you can see here. That's gonna be my left-sided lead. And similar to CAS, I always do an ipsilateral approach. Basically, I follow the first needle right down. And because I came off the spinous process just a little bit, my second needle is basically gonna come between that T12 spinous process and the needle I just placed. So I'm gonna take it basically to the same depth I brought the first needle, and now I'm gonna get the LOR syringe a few millimeters later. I'm gonna just advance it, boom. And I just lost it right after I got there, so it was perfect, and I can see the depths are about the same. And now I have these 2 needles that are basically right next to each other, 2 tips, right at the midline, right over the spinous process shadow from T12 to L1. And now that I already have that first lead favoring the left side, I'm gonna take the second lead up the right side of it. And again, because of this cadaveric epidural space, it's gonna be quite floppy and wide. But this is a good opportunity for us to talk about some of the things we can do here. You can put some English on the stylet. You can advance with little punches or jabs. You can move slowly. So I encourage you, if you're learning, if you're a fellow or you're getting more into stimulation, to try different ways, because every individual is going to give you different challenges. So I got to that location and I advanced that first lead a little bit. You don't have to do that, but I did that just so I could give myself some ability to pull that down. The second lead I held right in place because it held a little bit better. So I took out the 14 gauge 2E. And now I'm going to bring those leads right to where I want them. So the left one is a little bit advanced. I'm going to bring that down so the tips are right at that T8-9 disc space. And now I'm covering basically the bottom third of the context, or right at my sweet spot. So basically between the bottom third and the middle third. Now, there are different anchor systems. This is just a simple cylindrical silicon anchor, but there are obviously advanced ones, whether it's Click, Swift Lock, Injects, or other systems, which I typically use. But in this case, we used a very basic one. Typically for an implant, we would have good lighting, we would have suction, we would have electrocautery. I had none of those things. So I was just given a 2.0 silk, and we only had one basically for the entire day. So in this situation, I use this 2.0 silk to go through one simple eyelet. What I usually do is I use a 2.0 non-absorbable suture, and that's 2.0 Ethibond that's braided. And I actually cut it and I hand tie it, because I like to know that pressure of the suture. I like to feel with my index finger the actual knot itself. I put in 4 throws because suturing this anchor is the most important thing. And I put at least 2 sutures per each anchor. If I kind of feel a little wishy-washy, like I'm putting this in a 90-year-old patient where her ligaments might be a little bit more challenging or loose or floppy, then I'll put in a third anchor suture. And I use an SH needle because it has a nice curve. It comes right out. So just clip the tails there. And now we'll go to the IPG site, which we preoperatively penned around the left upper buttock area. I'm just re-outlining that location. What I'm showing you here is where I typically put the incision is between the interface of the metal and the polyurethane. But some people choose to put the incision actually cephalad to the IPG and then tuck it down. Either way is fine. I'm just showing you what I do here. Typically that incision is 3.5 to 4 centimeters, depending on which IPG and which system you use. So you can see I'm drawing a straight line here, and I'm approximating Longer's lines. Longer's lines are those lines you see on the skin that kind of fold over, and that gives me the best cosmetic effects for afterwards. So I typically use an 11 blade. In this case, I've got a big 10 blade. I can use a 15. So I'm getting through. For this rechargeable system, you want the depth to be no more than 2 centimeters because you need to make sure that interface is quite good. But for other non-rechargeable systems, you can go to a depth of even 4 centimeters if you wanted to. So really understand that depending on which system you're working with. I would typically use electrocautery here just to create a nice shelf, but I don't have that. So I use an Army Navy. I use my 10 blade. I would typically also use a METS for dissection or hold the tissue with a SENS. But again, we were limited with the instrumentation we had. I did use a heavy scissor simply just to demonstrate to all of you what to do with the METS. The point here is to go in closed, open, and spread. Go in closed, open, and spread. You do not want to cut any of this tissue. You don't want to cut a feeding vessel that could lead to a hematoma in the IPG pocket site, which could be, traumatic and complicated later on. So for the most part, it's a combination of electrocautery and blunt dissection. You don't want to do too much blunt dissection for the fear of developing a seroma, but you need to do enough here, obviously, to make sure you're not cutting through vessels, which could be problematic. Typically use a template here, not the actual IPG, but since I didn't have one really, I was just using the actual IPG to Samir's point regarding infection prevention. Now we're going to go on to the tunneling section. You can see here I put in a bend, a little J-tip in order to help with steering to ensure that I can maintain a relatively shallow location for that tunneling tool. Now, typically, when I was at UCSF, I taught fellows to always go from the spine towards the IPG pocket, just to make sure you don't puncture the spinal canal. But of course, very advanced practitioners sometimes will just go from the IPG site towards the spine as long as they ensure they know their depth of that tunneling tool. A few key points here is to really, that shelf that you create initially from the anchor site, just follow that in. There's no point in making a new plane here. That plane is very deliberate, because what I'm trying to do is have my eventual tension relief loop fall flat in that. You don't want those loops trying to pooch out of the incision itself, and it should be a very smooth process. There shouldn't be major resistance or jerking that could signal you're either too superficial to the skin or that you're in muscle. So now I take out the rod basically, and the tunneling straw is all that's left in place. So I'm pulling that out. Really ensure that you don't poke yourself or poke through the drapes from an infection, of course, and safety standpoints. So I take those leads and I place them through the straw. And it's really important to sort of understand how the tension relief loops want to lie. Sometimes they have their own sort of way where they want to sort of twist the opposite way you want them to lie. So really try to understand the natural behavior of those leads as they want to fall in, because it's really important that the tension relief loop lays flat in the coronal axis of that anchor site. If you have a lead that's wanting to pooch out, that could eventually work its way out and expose risk to infection over time. So you take out the Wheatlander, place all of that in, and I always want to just see how it looks without any sutures in place. I want to just make sure that it lies flat and that everything looks happy. So I'm really making sure I'm pushing the tension relief loop into the shelf that I created very early on. And now I've got the two leads sticking out of the IPG. This is where I change my gloves. I get a wet to dry. I wipe the contacts off very well. You don't want any heme or adipose tissue sticking on those contacts, which could impair your stimulation. Super important to do this because this is why those things cost so much money. You really need to make sure you're doing a good job. Typically here, once you get the lead in place, you would actually have screw holes, but in this particular situation, I had a fake IPG so that I could not screw anything down, but nonetheless, there were holes where I could place the leads in place, as you can see I'm doing here. I want the writing out for this rechargeable system. And then once everything is anchored in, as far as the leads in the IPG, I place all of that underneath into the pocket site and everything lays flat. So I was happy with how all that looked. I typically use a normal saline irrigation, 2030 Vicryl, and then Dermabond plus minus monocryl, and we can go into that later. Thanks, guys.
Rama, that was amazing. Thank you so much. And it's really refreshing for me to see that. I do things a lot like you, and I look up to you, and you've always had an amazing skill set. So that was wonderful. Now, please stand by just in case we have time for any questions that the audience may have. But moving on to the demonstration of technique of DRG, for the video, we actually had Dr. Jason Pope do it, mainly because of the fact that the best in the business, Jackie Weiswein, was not available that day. But Jackie's here with us today, and she's going to take us through the demonstration itself. Jackie, the floor is yours.
Thank you for that introduction, Cass. I really appreciate it. All right, well, I look forward to helping you start this.
Jackie,
Basically, I unmuted myself, right? So right now we're looking at Jason. What he's done is kind of looking at this vertebral bodies, and what we're doing is trying to square off the pedicles. So it's important that you're looking at the place where you're going to start and understand that your trajectory is going to be the most important thing. If you have a bad trajectory, you should not continue to just move forward and say, well, I'm going to just force this. Nothing about DRG is about force. Everything is just about like finesse. So what you can see is now Jason is actually measuring from the area where he wants to deploy the lead through that foramen and bringing it down a little bit further. So you can see he's kind of drawn his trajectory out with the needle so that he knows where he's going to enter under fluoro. Now, what this happens to do is like place your sheath when it's deployed through the epidural space in a perfect area so you can just follow the trajectory and go out. Everything about this is, again, finesse. it should not be force. So you're going to get your epidural access. This is again a modified 14 gauge 2E needle, and you can see that the access is a little bit more lateral. We usually come to a kind of paramedian approach, but this is a lot more lateral. Again, if you follow the tip of that needle, you can see that it's kind of aiming toward that foramen. Important thing is also you don't want to pass the midline. So you can see he's being very careful as he's approaching the midline and then about to do his loss of resistance technique. And however you do your loss of resistance technique is fine. It's just a matter of where you're going to enter. So you don't want to enter too high in the space, and you don't want to enter too low, and you don't want to enter too past the midline. It's got to be kind of Goldilocks. And honestly, that's the thing that you need to be careful about. Now, the sheath is the one that we use most of the time, is this heavily curved sheath. There's actually a gentler curve as well, but the heavier curved sheath makes it a lot easier for many of the areas that you're going to apply. Now, there's a little hub at the end there, and that hub is so that you can adjust where it's going, and then you're going to lock the lead into the place there. So anytime you're going to adjust the lead, advance it, you're going to have to unlock it. Now, you don't need to lock it down all the way, but you need to make sure that it's locked somewhat. The other thing you need to make sure that you recognize is that that little hub on the end there, you can squirt some fluid through it so it can get some saline coming out the end so you can loosen the lead. Now, this sheath is somewhat firm, but it's also got a lot of torque on it. So if you don't handle it correctly, you can put some unnatural forces on it. Now, what you're seeing is Jason fed it very gently by putting that curved tip in the end. And you can see those two white hash marks. The first one indicates that you're at the tip of the normal lead. The normal needle, and the second one is for the longer needle. Now, what's Jason's showing is that he's got the bevel facing upward or towards the head, and you always want to make sure that while you're being careful, you're keeping the hub in the same direction of the needle's bevel. So again, the hub indicates which direction that curved end of the sheath is facing. So it's like a one-to-one turning there. So be very careful, again, in the way you're turning it, because you don't want to be windmilling in the epidural space, but you just want to be careful because once it's in there, it's going to be in a little tighter. Like Rama was saying, you have the resistance from the CSF in there as well. So it's going to make it a little tougher for you to drive things. But you just have to remember, keep an eye on where the direction of that hub is going, because that's going to tell you where the tip of your sheath is. So now Jason's going to place that through there. And again, going to advance it until he gets to that first white hash mark. And as you can see, that first white hash mark is at the tip. Now he's going to go a little bit further, and he's doing this under live, and you can see he's aiming slightly up, and he's kind of missing the chin of the pedicle. So you see, as he gets close there, he's rotating it to the right, so it's going towards the pedicle. Now you're going to watch him do this, and it's not a battering ram. So what he's doing is very gentle, because if you start like firmly pressing that lead out, you can bend and kink the sheath. And that means if you kink that sheath, it's going to create like a crimping on the lead, and you won't be able to deploy the lead. So the most important thing is you're going to kind of just gently go and tap, 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 because there's a matrix of ligaments in that foramen, and you want to just be able to find that hole, and it's just going to pop through. And once it does that, you're going to be in the right spot. Now, Jason doesn't get a lateral in this, but I recommend that once you do get the lead out the foramen, that you get a lateral. So before you make your strain relief loop, because that's going to save you a lot of time if your lead is not in the appropriate position. Now, again, this is going to be important. So you're going to unlock now the end of the hub. And what you're going to do is you're going to begin to retract the sheath and advance lead like a Seldinger technique, so that you can move the sheath back into or near the hub of the needle. Now, the thing you have to be aware of is that the most important step that's happening is right now. This is the locking mechanism. So when that lead starts hugging the pedicle, that's the first lock. So even if you put like a bunch of bows in there, it doesn't really matter. What you really need is that lead to hug the pedicle, because that's how you lock it. Now, you can see that Jason didn't actually pull everything back. What he did is he pulled it back and started turning the tip of the sheath up, and so he could advance a little bit of the lead and make that superior loop. And that loop just really went perfectly. Now he's going to turn everything almost 180 degrees south, and he's going to use that bend of the sheath to start creating that inferior loop. And you can see what happens is that he starts making that bend. And then at this point, you kind of have to decide, is the lead too firm or what's going on? And so you can see he's going to pull back a little sheath, because that makes the lead a little softer as you're making your strain relief loop. So now he's going to advance some lead while he's retracting the sheath, so that the lead starts making the inferior loop. Now, the way you finish that inferior loop is kind of by turning everything back in the other direction and essentially just pushing the lead up and making another superior type loop. Now, Some people put more than the amount of loops that Jason's putting in. So this is just the one superior and a good inferior. And now he's going to advance a little bit more lead. Now, ideally, you really don't want the lead to be going past the vertebral body above and below, because if you're going to do multiple levels, you want to have some room. You obviously want to start with the most superior level first, but now to remove this, you have to be careful. So removing the needle first, because the sheath is much longer than the needle. And now, very carefully, he's advancing the sheath, the lead through the sheath, while he's retracting the lead and, the needle and the sheath simultaneously. And you can see as it gets close at the end there, he's still got a little of the stylet to hang on to, but as he gets almost out, he's able to grab the lead at the skin so he doesn't pull the sheath and the lead together out, but leaves the lead in place with the loop. Really nicely done. I made it look actually much easier than it is. So don't be, worried if you can't do it like Jason in 3 minutes like that.
Jackie, that was wonderful. Thank you so much. And obviously, just like everything else, it takes some practice to gain the skill set and to do it. Thank
Absolutely.
you.
Thank you.
Please stand by just in case there are any questions. But in the interest of time, we're going to move to Sloan Yu. We saved the best for last. He's going to talk to us about how he places a stimulator for cluneal nerve stimulation. Sloan, the floor is yours.
And thank you very much. So obviously, I'm not going to be discussing spinal cord stimulation. I'll be talking more specifically about peripheral nerve stimulation. So PNS is a new exciting technology for neuromodulation. The superior and medial cluneal nerves are two potential neuromodulation targets for any type of lower back pain. So superior cluneal nerve, as we know, runs through the top of the iliac crest, and is often trapped in osteofibrotic tunnel through the iliac crest, causing referred pain to the buttocks and sometimes to the groin and the IT band. So the way it often presents is patients will come in with a lot of pain and they'll point specifically to the top of the iliac crest. When you palpate, you'll notice that their maximum center of tenderness is a little too superior, a little too lateral to be facet or SI joint. And if you see that, think of superior cluneal neuralgia. And the way you diagnose that is how you diagnose any type of peripheral nerve entrapment. You do a small diagnostic anesthetic block, and if that takes away a significant portion of the patient's pain, you can proceed with a potential PNS trial. I will tell you my own clinical experience. I've had patients who have had 10 plus years of pain, tried everything, including high frequency, low frequency, burst SCS trials, had failed epidurals, and even failed surgery, only to have 100% relief with the superior cluneal nerve block and permanent relief with the PNS implant. The medial cluneal nerves, as we know them, is the lateral branches of S1, S2, S3, which give innervation to the SI joint, and you can consider a PNS implant and trial in lieu of repetitive RFs, or if patient doesn't respond well to RF. So I want to quickly show you an implantation of both those and an explant too, and as fast as I can, so we can start the video. So here you see the kit for the system. You have your needle on the left. You have the actual lead, which is the blue thing I'm touching right there. The pink is the receiver stylet. And what's interesting about PNS is you have this, what we call a lead blank, which is used to break through fascial tissues when you go in the periphery system. So not something you experience in SCS. In the PNS, you often will see fascial tissue that will impinge your lead. So, what I like to always do is put a good bend on my needle for this superior cluneal nerve implant. And that will help me steer it a lot better. So here's my target. As you can see on the right, I have my needle. Where I want to touch down is kind of right where the tip of the iliac crest is, and then I want to go put my stimulator through that. So this is the actual lead of a PNS system, very similar to an SCS system. This is the 8-contact lead. It's pretty strong. It's pretty strong material, so you can pull on it, and that is the steerer, very similar to an SCS system that we're used to. And yeah, you just turn it and you steer just like the SCS system. So I like to lay it out on my patient, and then where my actual beginning point is, I like to go parallel to the top of the iliac crest and kind of go right in the middle, right where the patient's midline is. I use an 18 gauge to kind of introduce my 14 gauge needle. Again, I put a nice little bend on it, and so I can have a good amount of steering, which becomes really important because you definitely want to stay above the iliac crest as you advance. So as I advance, you'll notice that I'm trying to keep my needle bent upwards. So I'm always staying superficial to the crest. You don't want to dive deeper to the crest and find yourself posterior to it. So I'm staying superficial the entire, staying anterior. And as I advance piece by piece, I kind of go over bone, and like we always do in most of our cases, if over bone, you're safe. And once I'm over bone, I turn my needle, so now it's now driving downwards. So I want to kind of, the actual crest will actually come downwards, so I want to keep it downwards. And I want to position it right on top of the iliac crest there. And the next thing I do is I will pull out the stylet, and I will use my lead blank, which I talked about is a strong, very strong metallic little rod that bends. And I'm going to use it, I'm going to push it so I can actually create the area I want my lead to go through. So it's a little bit too anterior there, so I'm making a track. So you can see on the left there, I'm going to make the track so it kind of falls right above the top of the iliac crest. So that would be a good placement there. So I like to pull the lead out. Now I'm actually going to take my peripheral nerve stimulator, I'm going to insert it. So this one actually has a tine system. So in order to prevent the lead from migrating, you can see those little tines on top of the lead. So this prevents any backwards migration. So I'm going to put my lead in. They don't show it here, but the next thing I do is I would take a lateral image after it's correctly. And in the lateral image, you can see that I'm kind of right where you expect the iliac crest to be, right kind of between the 3, 4, 4, 5 area, and it's sending downwards. What you probably want is the lead to be right around where above where the facet line is. Each patient's a little different, I noticed, but you definitely want it to be kind of descending downwards. So there you can see is the lateral plate, is the AP view. So I'm kind of right on top of the iliac crest there. I pull my needle out, and the next thing I do is I actually will take, after I take my needle out, I will take the actual, the driving blue stylet that's inside my needle out. So sometimes it gets caught, so I have to actually cut it off. And the next thing I do is I want to put my receiver in. So this receiver allows the connection between the actual computer chip inside the lead near the actual contacts. And this is, I'm actually pulling on that to show you that the tine system does a good job of preventing it from migrating backwards. So you can pull, it's pretty tough and it won't migrate that much backwards. So next I take this pink receiver, which help extend, it's like the handshake between the actual leads and the handshake between the contacts, and where you're going to put the external battery pad, what we like to call the wah. So I slowly just kind of slide in this pink receiver stylet into the lumen, and I just slide it piece by piece. Don't want to kink it. They give you 2 in each set, so in case you kink it, you can try it again. But definitely take small little bites, and then you're going to push it all the way until the very end. So and then that's going to be right about there. And maybe I don't know if you can see it, but it's kind of where it stops. There's a hard stop there. And there's actually a little marker you can see that you know that your receiver's all the way in. Next, you'll have your rep, and you will actually use the external battery and the little receiver, put it on, test it, make sure the patient's getting stimulation and paresthesia over the area of pain to know that you're on top of the nerve. So that's really good about PNS, is that if you're not sure if you have the right placement, you just test it. And they'll feel it if you're on the right spot. If they don't feel it, you gotta try again. So the next thing I want to do is make my pocket. So obviously this is not going to be the same size pocket as the IPG because there's no battery inside. You just want to make sure your pocket is past the second receiver marker. So there's like a little dark marker there. You want to make sure your pocket is past that second marker. So that means my pocket placement is going to be right about there. So I take a little 11 blade and I cut about 1.5 to 2 centimeters, a little pocket. Doesn't have to be too deep. It just has to go through the skin. I used to make my pockets really small, but I realized that if you make them smaller, it really makes putting the actual coil you're creating more difficult. So I'm going to cut the little pocket. I'm going to use my scissor to just dissect a little around it, just staying more superficial. And then I'll actually use my needle driver to kind of just open up a little space superficially around. Don't want to go too deep, and just to make sure I have a nice little pocket created. Next, I'm going to do my tunnel. So I like to do something that's called a reverse tunnel, where I take my stylet, I put it through, and I take the sheath through here, and then I basically just reverse it back. So you can see this is a little something I call the reverse tunnel. It quickly just allows you to just drive your stylet through, and then you just put it through. And when you put it through, you just like an SCI system, you just pull right out. And remember, the tine system is allowing you to, it's not going to migrate much because of the tine system is actually holding it in place. Next, I use a little knot. So when you create this knot, it creates a place so that no bacteria can go through the lumen. It also holds the receiver stylet in place. So I'll create a little knot, and I'll try to get that knot as close to my receiver pocket as much as possible. And then the next thing I want to do is create my coil. So this coil is like a little anchor system. It helps ensure that forward migration of the lead doesn't occur. So I use 2-0 silk to create this second coil. So you just snap it with your pickups and you create a little loop like that. And then what you do is you take a 2-0 silk and you go through the loop 2 or 3 times. And then you I used to like to use 2 anchors on the coil. So I use 2 2-0 silks and I create a little loop to ensure that doesn't break. You definitely don't want the loop to break, because if it does, that can create pressure on the skin and cause erosion. And that will also give you a complication. So, here I go. I just take my little 2-0 silks and I just wrap it around twice, 2 or 3 times. I often do it around the coil so that it will ensure the coil is in place. And then I'll quickly hand tie it. I'm probably gonna cut forward to save you my hand tying, but yeah, just tie it like you would any type of situation, and you tie it 3 or 3 times. But ultimately, that's what you're gonna get. You're gonna have 2 2-0 silks wrapped around multiple times around this coil, and you'll have a little coil, and you'll cut off the tail end. And when you have this little coil, the next thing you're gonna do is you're gonna take it and you're just gonna kind of make sure you put it into the actual pocket you created. And when you do this, make sure there's no pressure, because if the coil is not there's feeling pressure, the pressure is being pushed on the skin. Again, you may cause increased chance of erosion. Of course, you may feel it, so you want to avoid that. So I use my little pickups and I push the coil in, make sure there's no pressure. And then the next thing I would do, I didn't have one here, I'd take a 2-0 silk and I actually would suture the little coil I created to a deeper part of the fascia to ensure that there's no migration and that the coil doesn't rotate in an unnecessary way. And then I just use a 2-0 Vicryl, 1 deep, and then to close it. So the next I'm going to show you quickly is cluneal nerve placement. So the cluneal nerve, as the medial cluneal nerve, as you know, this is the lateral branches S1, S2, S3. So you kind of want to be medial to the joint, lateral to the foramen. And again, I'll use a bend, and this bend will help me ensure that if I actually will be over bone, and then I'll turn it to dive deep. So once I start diving deep, I'm going to try to grab it right on the lateral part of the foramen, in between the joint and the foramen. And then once I get it in the correct position, I'm going to again, so this is, I just grab it. I'm going to again, so I quickly jumped forward because I had to do so much, but I just basically put my receiver stylet in. And as you can see, it's lateral to the foramen, medial to the joint. You take a lateral, and the point of the lateral is that you definitely want to actually be seeing it. You want to see the lead actually come and touch the bone. As you can see, there's actually, the lead is coming and touching the, getting very close to the actual sacrum, ensuring good contact along those medial branches. So again, it's a very similar concept. You'll take it out and you put the receiver stylet in. So the receiver stylet, again, is the handshake that basically allows the connection between the contacts and the computer chip. Then you'll go ahead and stimulate just like last time. They'll feel it on that side joint area, and if you successfully did it, they'll feel it, and that would be confirmation that you have the right placement. The last thing I think I want to show here, so I'm going to do my tunnel really quick for you again. I do the reverse tunnel where I take my stylet, I put it to my actual receiver pocket, and then I take my sheath, I put the sheath through, and I like this system because you're going lateral, so you're not actually going towards the spine, and you're not going towards the actual lead, because you may actually penetrate the lead if you go towards it. So, and then that's a quick tunnel. And I'm going to save you the actual coil part. So the coil part will be very similar to what you saw previously. I'll coil it and then I'll implant it. The last thing I want to show is what's it like to explant a system. So if you want to explant, you just grab it here. You take the coil out. And then what you want to do is I'll take a shot for you to show that where the superior cluneal, explant the superior cluneal for you. The superior cluneal is there, and all you do is pull. So I just want to show you what's like with the tine system. You can still pull it, and there'll be a little resistance, but you can easily pull it, and it comes out quickly, and the whole system is now out of the patient. And you can see that the whole tines is there, and so are the contacts. Yeah, that's it. Thank you very much.
Sloan, that was amazing. Thank you so much. And that was a phenomenal demonstration. Nothing I had seen before. So you got great hands. Unfortunately, we're almost out of time. So there's really no time for questions, but we want to honor all the questions that you may have. Please enter them into the question box and we'll email the answers to all the registrants of this webinar. I want to thank the entire faculty for doing a phenomenal job with this webinar tonight. I know that a lot of you are, thank you, Ramo, and I love your jacket too. Thank you, Sloan. Thank you, Jackie. Thank you, Krishnan. Thank you, Lawrence. Thank you, Samir, everyone, for joining us. I know a lot of you are already members of the Pacific Spine and Pain Society, but if you're not and you practice in the Western region of the United States, in California, Hawaii, Nevada, Washington, Oregon, Arizona, Colorado, New Mexico, please join. And there's no annual membership fee for the first year. And as I said earlier on, there's strength in numbers. The more members we have, the better we can do with our society. And please don't forget about our annual meeting coming up in September in San Diego. Hopefully by that time we can all travel and we can all see you there. So we have that program going for sure. Within the next 48 hours, you can go to this link and claim your CMEs. And there's also a handout that you can download on this webinar as well. It's a PDF. It's inside the links. And we can also email you the link if you decide to get your CME credits later. If you're watching a recording, there's another way for you to get the CMEs, and this is the link for the recording CME. With that, I believe that's the end of the slides, and this is September 11th to 13th. That's our annual meeting. I hope to see all of you there. Thank you all so much for joining us, and I hope this has been useful. Have a great evening.
Great job, everybody. Good night.